Welcome to this fourth lecture series on the anatomy and physiology of the urinary system. In this particular lecture, we are going to look at the structural organization of the urinary passageways, as well as the physiology of urination, which is also called micturition. To bring you to perspective, we've been looking at a series of lectures on the anatomy and physiology of the urinary system. We have already done the first three. The recordings are available, you can check. Now we are now doing the fourth one. There'll be yet another one that we do last, which will be on development and malformations of the urinary system. So in this particular one, we're just focusing on the urinary passages, anatomy, and physiology of micturition. This is what you're going to learn. We'll first review the components of the urinary system in brief. We'll also outline the various components of the urinary passages in brief. Then now talk specifically about various components of the urinary passages. We'll start with the Pelvicalyceal system. Then we'll talk about the ureters. We'll talk about the urinary bladder. And at the time, we'll also explain the process of micturition. And lastly, we'll talk about the urethra. So starting with just a brief review of the components of the urinary system. You remember from our previous session, we said that we can look at the components of the urinary system in two ways, either anatomically or physiologically. Anatomically, we just look at the organs that make up the urinary system. And there are these four organs: kidneys, ureters, urinary bladder, and urethra. Physiologically, we focus on the functions played by these structural entities. With that in mind, we can divide these entities into two. There are those that form urine. We call them the urine-forming structures. And at histological level, this is the nephron, which is a functional unit of the kidney. And then we have the urinary passageways, which is the subject matter of this discussion. It is a path used to collect urine. So basically, the urine collecting structures. If you look at it in strict understanding, you'll notice that the kidneys have both urine-forming structures, which are the nephron, but also the urine collecting structures, which we call the Pelvicalyceal system. This image captures for us the internal structure of the kidney. We've looked at this before. We agree that the kidney has a capsule on the outside, which we call the renal capsule, that protects it. Deep to that is what we call the renal parenchyma. The renal parenchyma refers to the region of the kidney that contain the nephron, which is the function unit of the kidney. This renal parenchyma has this outer region, which we call the renal cortex, and inner zones, which we call the renal medulla. In particular, the medulla consists of pyramids, which you can see there. The pyramids tend to contain the collecting ducts, as well as some segments of the loop of Henle. The renal cortices, on the other hand, refer to the regions that contain the renal corpuscles, but also contain convoluted tubules. The renal cortex has these cortical arches, this region, and the extensions of the cortical tissue into the medulla is what we call the renal pyramids. Then the third portion of the section kidney is this pelvicalyceal system, embedded within what we call the renal sinus. The renal sinus, this region with the pelvicalyceal system, the blood vessels, and fatty tissue. Now we can state the components of the urinary passageways. Now, the apex of the renal pyramid would look like this. Urine will come at the apex of the pyramid to empty into a minor calyx. These channels you're seeing within here represent the collecting ducts, as well as also medullary ducts. Medullary ducts are unions of 2 or more collecting ducts. So like histologically, perhaps that's a collecting duct, that's another collecting duct, and that's a medullary duct. We can still call them papillary ducts. Now, papillary ducts open at the apex of the pyramid, and we can see those various openings at that point. So these are papillary ducts that open at the apex of the pyramid. This region of the pyramid where the papillary duct opens is called the renal papilla. The papillary ducts empty at the renal papilla by pouring the urine they have into minor calyx. Then from minor calyces, urine goes to the major calyces. From the major calyces, urine goes to the renal pelvis. From the renal pelvis, urine goes to the ureter. And from the ureter, urine goes to the urinary bladder. From the urinary bladder, urine goes to the urethra. This is how the urethra will appear in females. And this is how the urethra appears in males. So these are the components of the urinary passageways, if I was to say that in brief. Now let's look at each of those components. We start with the pelvicalyceal system. The pelvicalyceal system is the network of urine collecting structures from the kidney, and they are centered within the renal sinus. When you talk of the renal sinus, we're talking about this region. It is the extension of the renal hilum into the kidney. This is the renal hilum, the point where structures enter or leave the kidney. So this renal sinus is lined by renal capsule, which is this one. So it's lined by renal capsule, and it contains a number of structures. Other than the pelvicalyceal system, the renal sinus contain renal blood vessels, so renal artery, renal vein, and their branches, especially the segmental component of them, as well as adipose tissue and nerves. This image shows you the renal artery, the renal vein, and there are various segmental branches within the renal sinus, also fatty tissue and pelvicalyceal system located within the renal sinus. Now, in particular, when you talk of the pelvicalyceal system, what are we referring to? The pelvicalyceal system consists of the following. The fact that we've mentioned the papillary ducts, and that papillary ducts open at the summit of the renal papilla. Now, this summit of the renal papilla has a lot of perforations. This perforated region is known as the area cribrosa. So this is the summit of the renal papilla, containing several perforations of representing openings of the various papillary ducts. So we call this one the area cribrosa. Papillary ducts open at the area cribrosa by emptying into the minor calyces. We have about 8 to 12 minor calyces on each kidney. Minor calyces join to form major calyces. We have about 2 to 3 major calyces on each kidney. Remember, the major calyces then join to form the renal pelvis, which is only one, and the renal pelvis continues into the ureter at the ureteropelvic junction. Now, something we mentioned some time back is that each minor calyx drains a lobe of a kidney. So if we say that you have 8 to 12 minor calyces, it simply means, therefore, that you have about 8 to 12 renal pyramids, and that means 8 to 12 renal lobes, because remember, renal lobe represent one pyramid and all the surrounding cortical tissue. So this image shows you the pyramid emptying to minor calyx, pyramid emptying to minor calyx. So we have a total of 8 to 12 pyramids. That means 8 to 12 renal lobes, 8 to 12 minor calyces. The minor calyces drain into major calyces, and major calyces empty into the renal pelvis. Now, the walls of the pelvicalyceal system, as well as the walls of the ureter, usually contain smooth muscles. The smooth muscles within the walls of these urinary passageways help to propel urine towards the urinary bladder for storage. And so the position of an individual may not matter much, whether they are lying horizontal or they're vertical. Chances are that the urinary bladder will still fill because of the peristaltic activity within the urinary passageways. Now we can take time to go through the anatomy and physiology of the ureters, having talked about the pelvicalyceal system. So these are the ureters, the ones represented by the green shading on either side. The ureters are muscular tubes. Usually they have peristaltic activity that is experienced about 1 to 5 times per minute. And those peristaltic activity are the ones that propel urine from the pelvicalyceal system all the way to the urinary bladder for storage. Because of these peristaltic activities, the urine entering the urinary bladder may also enter in spurts or jets, which are synchronous with these peristaltic waves of the urinary bladder, of the ureter. Of course, the length of the ureter will depend on the height of a person, but it will range from 25 to 30 centimeters long. In adults, they descend anterior to the posterior abdominal wall. So they're basically retroperitoneal structures between the posterior abdominal wall and the paratoperitoneum. So they descend in front of the musculature of the posterior abdominal wall all the way and pass through around the pelvic brim to enter the pelvic cavity, where they eventually empty into the base of the urinary bladder. So here they're within the abdomen. That segment is called the abdominal ureter. And here they're within the pelvis. That segment is called the pelvic ureter. This is a point at which they cross the pelvic brim related to the common iliac vessels, which are branches of the descending aorta or confluence of the inferior vena cava. The walls of the ureters are relatively thick, and we are going to look at the histology shortly, with the lumen relatively narrow, maybe just 3 millimeters. To add to that insult, the lumen of the ureter is anatomically constricted in 3 sites, which I want to mention. One, the junction between the renal pelvis and the ureter is a point of narrowing. We call that ureteropelvic junction. The second point of narrowing is where the ureters cross to enter the pelvis. So when they cross the pelvic brim, the ureters there are slightly constricted by the common iliac vessels. And lastly, where the urinary bladder receives the ureter, the junction between the ureter and the urinary bladder, we call that ureterovesical junction. And in particular, this is the narrowest part of the ureter. Now, why am I teaching you points of narrowing of the ureters? It is important to note because these are the potential sites for renal stone impaction if somebody has renal stones, what we call urolithiasis. If somebody has urolithiasis, then these renal stones are likely to impact in those regions of narrowing. So even during imaging, these are the parts that are keenly checked to determine whether somebody has renal stones. Let's talk about the blood supply to the nephron. We'll majorly focus on arterial blood supply. So the ureters, did I say nephron? No, ureter. Now the ureters are supplied by several arteries which supplied segmentally. So there are those vessels which enter from up. For example, we have branches from the renal artery, branches from the gonadal vessels, branches from the common iliac, internal iliac, vesicle down here, uterine artery, as well as some direct branches of the aorta also just supply the ureter. This is a very rich source of blood supply, and all these arteries form a very good longitudinal anastomosis on the wall of the ureter. Now, what's the clinical implication of that? It means that each segment of the ureter is well vascularized, receives good nutrients. That means that if there is a segment of the ureter that has a problem, it can actually be surgically resected, removed, and the good parts anastomosed, and you still expect good healing. Because we are saying each segment of the ureter is richly supplied by those segmental arteries. So it's possible to do resection and anastomosis of the ureter with good healing outcome because of the rich and segmental pattern of blood supply to the ureters. Now, something else to note, if you look at the arteries that enter the ureter on the upper side, which means that the arteries that supply the abdominal ureter, those arteries tend to enter the ureter from its medial aspect because the arteries are more medial, and so they enter the ureters on the medial aspect. That's a bit different from the arteries that enter the ureter in the pelvic region. So the arteries that supply the pelvic ureter tend to enter into the ureter from the lateral aspect. Again, what are the clinical implications of that? It means that, therefore, if somebody wants to operate on the ureter or around this region, know, therefore, that on the abdominal side, the medial side is not a safe zone to cut, but the lateral side is a safer zone to manipulate. But in the pelvic ureter, we flip the coin. The lateral side is not safe for interruption, but the medial side is relatively safe for manipulation. So those are the implications clinically. Let's talk about the histological structure of the ureter. How does the ureter look like histologically? In cross-section, the ureter seems to have a star-shaped lumen, which looks like the one displayed there. The wall of the ureter itself is very thick, as I mentioned earlier, and it consists of 3 histological layers. The outermost layer is what we call the adventitial layer. The adventitial layer is this zone here. It basically contains loose connective tissue. This loose connective tissue also has scattered fat cells. It also has blood vessels and nerves. These are the ones within the adventitial zone. So this image still captures for you the outermost zone. This shows you the adipocytes and blood vessels, which are found within the adventitia of the ureter. The second layer from outside is the muscular layer. the muscular layer contains smooth muscles on the wall of the ureter. The smooth muscles on the wall of the ureter are present in 2 or 3 layers. Now, for the lower parts of the ureter, there are 3 layers of muscle. The innermost layer tend to run longitudinally, which means along the length of the ureter, so we call it the inner longitudinal layer. Then there's a middle layer which tend to run in a circular pattern, and yet another outer layer that also runs longitudinally. So we have inner longitudinal, middle circular, outer longitudinal. However, in the upper parts of the ureter, the outer longitudinal layer is usually absent. So the upper ureter will tend to have the inner longitudinal layer and outer circular layer. But in the lower part of the ureters, inner longitudinal, middle circular, and outer longitudinal layer. Now, sometimes you might confuse the arrangement of smooth muscle in the ureter with those ones of the GIT. Remember, in the GIT, we have inner circular and outer longitudinal layer. In the ureter, we have inner longitudinal and outer circular layer, especially for the upper ureter. The arrangement of muscles within the lower ureter is similar to the arrangement of muscles within the urinary bladder wall. And so I'll not talk much about the bladder histology because the same concept, the only difference here is the thickness and the size. So this shows you the muscular layer of the wall of the ureter containing smooth muscles. The innermost layer of the ureter is called the mucosal layer. The mucosa of the ureter consists of 2 things: the lining epithelium and its lamina propria. The lamina propria of the ureter is very prominent, very thick lamina propria. This lamina propria contains dense fibrous connective tissue. It's collagenous fibers. So it's a very thick fibrous connective tissue zone beneath the epithelial lining. Now, the epithelium itself of the ureter is made up of what we call transitional epithelium, otherwise known as urothelium. Urothelium is very unique to the urinary passageways. It is present from the calyceal system all the way to the urinary bladder. Let's talk more about the transitional epithelium. So it's a unique epithelium that lines the urinary passageways, and that is why it's called urothelium then. The unique thing about this epithelium is that it is impervious to both water as well as ions, and we really need that to happen. Otherwise, you'll be having leakage of urine from the ureters back to the circulation. You'll be impairing the mechanisms of urine formation and excretion. So the urothelium is impervious to water and ions. It lines the urinary passageways all the way from the renal calyces to the urethra. The upper segments of the urinary passageways will have a lower layered number of cells. Let me put it this way. The epithelium is stratified, yes, but the upper segments will have lower number of cell layers compared to the lower segments of the passageways, and that should make sense. So things like calyces will have about 2 to 5 layers of cells, but as you go down to an empty urinary bladder, you can even get up to 6 to 10 layers of cells. This image shows you one of the calyces where we have not so much number of layers, but look at that transition, the number of layers change. Even before we leave the calyceal system, we can see the thickness in this other end. This one shows you the epithelium lining of the ureter, now very thick as well. And we've said that the number of cell layers on the upper part will also be less than the ones in the lower part. The ability of this epithelium to become flatter when there is urine and unfold when there is no urine allows urinary passageways to accommodate the intermittent distension that is usually caused by urine during various phases. So the time that there's a lot of urine, the epithelium will be stretched and thinner. And when there's no urine, the epithelium will not be stretched, it will be folded, and it will be thicker as well. This image captures for you typical representation of transitional epithelium, what we call urothelium. Now, what do we notice about this type of epithelium? In principle, the epithelium is actually stratified cuboidal type of epithelium. This is to mean that there are several cell layers, hence stratified. The cells on the apical zone have rounded nuclei, giving us the understanding that the epithelium is predominantly cuboidal, although there are a few that could actually be squamous. So it's a stratified cuboidal epithelium, but there's some unique features about this stratified cuboidal epithelium. If you look at the cells on the surface, they seem to be very large, with very large nuclei, a lot of cytoplasm. And so that makes the cells on the apical zone to be really large or prominent. Because they are large, the cellularity on the apical zone is not as much as the cellularity on the basal zones, because the cells at the basal zones have less amount of cytoplasm, and so they'll appear smaller and clustered. The cellularity is high, but the apical zones have sparsely populated cells. There are two types of cells that we see on the apical surface of urothelium. There are these cells which project into the lumen like a dome, so we call them dome-shaped umbrella cells. But there are also these cells which appear squamous generally. We call them the flattened umbrella cells. So there are flattened umbrella cells, and we have the dome-shaped umbrella cells. Those two types of cells are present on the surface of urothelium. This image still captures for you that. So we have these flattened cells, and we have the dome-shaped cells as well. Another thing that we need to take note of is that the cells which are at the base tend to be smaller. I'd already mentioned that, because they have little cytoplasm, and so they tend to be crowded compared to the cells which are on the apical zone. I forgot to mention something, but I can still mention, not too late, that the cells on the apical zone, these large cells, some of them are also binucleated, as you can see there, even that one. So you see a number of binucleate cells. Not all of them are binucleate, but yes, they're still there, those ones which are binucleate. Last but not least, the cells in the intermediate zone, somewhere here, will therefore have variable number of layers as well as variable sizes. So those are the characteristics of urothelium, transitional epithelium. The urothelium or transition epithelium lines the calyceal system, the pelvis, the ureter, as well as urinary bladder. And so we'll not talk much about it again when we discuss the urinary bladder and urethra. Let's talk about the innervation of the ureters. Ureters receive both sensory as well as motor innervation. In particular, the motor innervation is by autonomic nervous system. So both the sympathetic as well as parasympathetic nerve terminals end on the ureter. The sympathetic terminals come from T10 to T12, so largely within the lesser and the least splanchnic nerves, as well as within the lumbar nerves. The parasympathetic nerves largely come from the middle three sacral segments, which go to the ureter. The motor nerves target the smooth muscles. So these autonomic nerves target the smooth muscles within the wall of the ureter. And the role of this innervation is basically to play a modulatory role. They don't quite initiate events, they just modulate the contractile events that occur within the ureter. Remember, it is made up of smooth muscles, so it has some intrinsic contractions in itself, but the sympathetic and parasympathetic offer modulatory role on these contractions. So maybe at that point, it's good to talk about the contractions which are experienced within the ureter. So ureter usually has contractile waves that originate from multiple sites within the wall of the minor calyces, having mentioned that minor calyces have smooth muscles. So there are some smooth muscles within the minor calyces that function as pacemakers. They can initiate impulses, and there are multiple. So those muscles within the minor calyces that can initiate impulses do initiate impulses and transmit those impulses through the muscles. So we are not talking about nerve conduction here. We are talking about the action potentials traveling between the muscles. Why? Because the muscles are interlinked with several gap junctions between them. And so we have a lot of electrical synapses between the musculature of the ureter. Now, imagine that as a wave. It started from up within the minor calyces. It will follow through antegrade direction all the way to the urinary bladder. So the peristaltic waves are carried in an antegrade direction from the minor calyces all the way to the urinary bladder. These are the waves that then occur in like 1 to 5 waves per minute, and they're the ones that are responsible for the spurt mechanism of bladder filling. The contractions of the ureter are enhanced by parasympathetic stimulation, but inhibited by sympathetic stimulation. Having talked about the ureter, we can now focus on the urinary bladder and micturition process. So the urinary bladder is located within the pelvis. It's a muscular bag that stores urine. The size of the urinary bladder varies according to whether it is empty or it is full. And that will also apply to the shape as well as the position. So in particular, when the urinary bladder is empty, it will be relatively collapsed. It's somewhat tetrahedral when it has less urine, but it will be a bit ovoid when it is full of urine, or circular. Again, of course, the size will be varying depending whether it has something. So when it's empty, it's smaller, and when it has urine, it is bigger. In terms of position, when the urinary bladder is empty, it will be entirely within the pelvis, just behind the pubic symphysis. But if the urinary bladder is full and perhaps very full, then it is a content of the abdomen. It will be above suprapubic when it is full. And that is important to note when you're going to catheterize, do suprapubic catheterization. Know that an empty one will be in the pelvis, and so very difficult to do suprapubic catheterization. But a full one, easy to do because it is in the abdomen. This shows you the urinary bladder in female. This other one shows you urinary bladder in males. So I've already told you that an empty urinary bladder is tetrahedral. Usually this empty urinary bladder will have a base, which is usually posterior or posterior inferior. It has a superior surface, which is on top, somewhere there. It has inferolateral surfaces, right and left. It has an apex, which is this one, and it has a neck which faces down. The bladder neck is down. So this is the tetrahedral. This is the superior surface. This is the inferolateral surface. We have right and left. The base is posterior and perhaps posterior inferior. This is the apex, which has attachment to the umbilicus. And at the neck is the inferior angle there. There are two openings into the urinary bladder from the ureters, and one opening that gives rise to the urethra. Therefore, we say that there are three openings in the urinary bladder, two for ureters and one for urethra. The region between the three openings is what we call the bladder trigone. This bladder trigone is usually posterior. The smooth muscle within the wall of the urinary bladder has a name. We call it the detrusor muscle. It is particularly found within the muscular layer of the urinary bladder. At the bladder neck, the urine is usually controlled by some sphincters, which we call urethrosphincter or bladder sphincter. So the sphincters are the ones that control urine output, whether in males or in females. There are two types of sphincters, though. We have internal sphincter and external sphincter. The internal sphincter is made up of smooth muscles. So they are at the thickening around the urethral openings into the urethra. The external sphincter, on the other hand, is made up of skeletal muscle. And so the external urethral sphincters are voluntary. You have conscious control over them. They are under somatic innervation. But the internal sphincters are involuntary. They are controlled by autonomic nervous system. This shows you the internal sphincter in female, as well as the external sphincter in female. Let's talk about the relational anatomy of the urinary bladder. We can start with the neck of the urinary bladder. The bladder neck is the one down. This bladder neck usually rests on the pelvic floor in females, but in males, it will be pointing at the prostate gland. The base of the urinary bladder is this region that is posterior. This base of the urinary bladder is related to the rectum. In males, it's related to the rectum. It's also related to the vesicorectal or rectovesical pouch. This is still in males. So this is the rectovesical pouch. The reflection of the peritoneum between the urinary bladder and the rectum, rectovesical pouch. It is also related to the seminal vesicles, which are these ones. Seminal vesicles produce semen. Actually, they contribute the largest volume of semen in males. Other than the seminal vesicles, you also have the vas deferens also being posterior to the bladder base. Now that is in males. In females, the base of the bladder abuts the anterior wall of the vagina, as you can see there. So this is the vagina, and this is the posterior aspect of the bladder wall. So this is the base of the bladder. The superior surface of the urinary bladder, which is up here, is usually covered by peritoneum, as you can see, and importantly related to the sigmoid colon. So the sigmoid loops usually make folds over the urinary bladder, as well as the coils of the terminal ileum, the last segments of the ileum, terminal ileum, also fall over the urinary bladder superior surface. The apex of the urinary bladder consists of what we call the median umbilical ligament. This is a remnant of the urethers, if you remember that from embryology. It's a remnant of the urethers. It attaches the apex of the urinary bladder to the inside of the navel, inside of the umbilicus. We call that the median umbilical ligament. The inferolateral surfaces of the urinary bladder are not covered by peritoneum like the superior surfaces. These inferolateral surfaces of the urinary bladder are related to the pelvic side wall as well as to the pubic bone itself. Now, this image captures for you the inferolateral surface of the urinary bladder and its relation to the pelvic side wall in male, and this other one captures for you the same story, but now in female. So that's the relational anatomy of the urinary bladder. Now we can talk about nerve supply to the urinary bladder. The nerves that go to the urinary bladder, we have both sympathetic as well as parasympathetic nerves. And they have both efferent as well as afferent functions. They form a very dense plexus on the wall of the urinary bladder, especially within the muscle layer. The afferent nerves, the sensory nerves, are responsible for carrying sensory information from the urinary bladder to the central nervous system. Largely, this sensory information will be regarding pain sensation, as well as sensation of stretch or distension, so to speak. This is what gives the information of bladder fullness. The efferent innervation can either be classified as parasympathetic, sympathetic, and somatic. The parasympathetic efferents that go to the urinary bladder cause the contraction of the detussor muscles. This will cause, therefore, bladder emptying. And so the parasympathetic efferents, because of their effect on contraction of urinary bladder, they're important for facilitating the process of micturition. Well, they also cause relaxation of the internal urethral sphincter, and that again facilitates the process of micturition. The second nerve patterns are the sympathetic efferents, which also terminate on the urinary bladder as well. Sympathetic nerves to the urinary bladder cause the internal urethral sphincter to contract, and so that prevents voiding, although that may not be the primary role. The primary role of this is to prevent retrograde ejaculation, especially in males. So tightening of the internal urethral sphincter by sympathetic stimulation is very vital, especially when a man is having orgasm, so that it prevents ejaculation into the urinary bladder instead of exterior. Perhaps it's for the same reason, therefore, that ejaculation is generally a sympathetic response, so that when the sympathetic stimulation is promoting ejaculation, the internal urethral sphincter also contracts so that the semen does not enter the wrong direction. Apart from parasympathetic and sympathetic nerves, we also have somatic nerves. The somatic efferents are basically the voluntary division of the nervous system that go to skeletal musculature. So they're usually carried within the pudendal nerve, and they in particular target the external urethral sphincter. This is the one that controls voiding voluntarily. The external urethral sphincter is what is targeted by the somatic efferents carried within the pudendal nerve. That is how the urinary bladder is innervated. Let's talk about the anatomy of the ureterovesical junction before we can talk about the physiology of the urinary bladder. Usually, we know that the urinary bladder fills gradually from the two ureters by the regular peristaltic waves that we've already talked about. These waves cause some spurts, or what we call ureteric jets of urine into the urinary bladder according to the peristaltic waves. Now, each ureter causes obliquely for some distance through the wall of the urinary bladder in this manner, or perhaps in that manner. So what you're saying is that the ureter does not come directly like this. The ureter causes obliquely for some distance within the wall of the urinary bladder. Why is that important? It is important so that the normal tone of the urinary bladder will help to compress the ureter, hence preventing backflow, preventing vesico-ureteric reflux. So the compression can be because of normal bladder filling, or even when somebody's micturating, there's a lot of pressure, contraction, or if somebody has applied external pressure on the urinary bladder, it should not allow backflow of urine. So the obliquity of the ureter within the bladder wall help to prevent reflux of urine. Compare that with this one where the ureter is short, and so it almost empties directly into the urinary bladder. This one will allow backflow easily. So the ureterovesical junction has an important anatomy that need to be considered that actually prevent reflux. Having said so, we can now talk about bladder physiology. And we look at bladder physiology in two aspects. There's a phase that the bladder takes to fill with urine, and there's a phase that the bladder takes to empty urine. So the micturition process consists of the storage phase and the voiding phase. Let's begin the storage phase, which is the filling phase. Assume that you just emptied your urinary bladder. The urinary bladder will start to fill gradually from the ureteric jets that you mentioned. During the phase of filling, the urinary bladder will accommodate quite a volume of urine. Now, the initial filling of the bladder is not associated with any sensation of increasing volume. This is because the bladder was already collapsed. So even though the volume of urine increases within the bladder, the pressure within the bladder wall doesn't increase as much because the bladder was already in a relaxed state, or rather collapsed state. So look at this. In this state, when it is empty, collapsed, the wall is even thick, very small. Compare that with this one when it is full, and you can see in this image, it's the full one where it's actually possible to do suprapubic puncture of the bladder. Why is it possible that the initial phases are not characterized by increase in intravesical pressure? Two reasons. One is the viscoelastic properties of the bladder wall. The bladder wall has elastic properties. It can relax, it can stretch. So that ability for it to stretch lowers the potential of it increasing the pressure because it can stretch. But there's also another reason. There's some inhibitory signals that are sent from the spinal cord because of the filling of the urinary bladder. As the urinary bladder fills, the sensations that enter through the dorsal horn of the spinal cord are inhibited at that dorsal horn. We call that one the gating mechanism. So these signals cause inhibition, especially of the parasympathetic efferents from those segments to the urinary bladder. And so that helps to prevent the contractions. Therefore, the pressures are not elevated as much. Those reflexes operate between the spinal cord and the urinary bladder. So in this image, we can see perhaps that there are some stretch receptors which have detected distension. If the distension not that much, when that enters, ideally, this should cause a reflex contraction by the pelvic parasympathetic outflow. However, because of the gating inhibition concept, the parasympathetic nerves become inhibited here. And so they fire less, and that means that they are accommodative of the increasing volume. The mean bladder capacity in adults will vary around 400 ml, but for practical purposes, most people will have already voided before even it reaches 400 ml. So we tend to void earlier than the maximum capacity. Now let's talk about the voiding phase, the emptying phase. Let's start with the urge. The first urge to void is usually felt in much lower volumes, actually. When the bladder volume reaches about 150 ml, it may cause some reflex mild contractions. Those reflex mild contractions can actually give the sensation of wanting to void. Of course, most people will ignore that one, and there's no big deal about that one. Some people may respond to void at that point, but most people will avoid the first urge, they'll inhibit it. So the bladder will continue to fill progressively from even that 150 to go to even 300, 400, or slightly beyond. As the volume go beyond 300 to 400, beyond 400, beyond 300, the pressures within the urinary bladder start to rise rapidly or sharply or markedly. Remember, initially, the intravesical pressure was held at relatively constant. But when we have large volumes of urine, the intravesical pressure now begins to rise rapidly. The graph is now steeper. And because of that rapid rise in the intravesical pressure, is usually marked increase in the sensation of bladder fullness and a stronger urge, therefore, to void. And so sometimes, again, people will void at that point or may not, again, void at that point. Now, of course, most people will void at that point when you have a strong urge for voiding. During the voiding phase, this is what happens. The muscles in the pelvic floor, as well as the urethral sphincters, usually relax to allow urine to pass through from the urinary bladder through the urethra. However, at the same time, the muscle of the urinary bladder wall, the detrusor muscle, usually contracts. And this contraction of the detrusor muscle increases the intravesical pressure that help to expel urine. So when urine is being voided, when urine is being passed out during micturition, there are strong contractions of the urinary bladder caused by what we call the micturition reflexes. So this image again captures for you that same concept. The earlier phases, no significant rise in the intravesical pressure, it's relatively constant. The first urge felt at around 150 though, but it will still continue feeling. But when the volumes reach between 300, 400 there, the contractions become more and uncomfortable and stronger urge to void. When we are voiding, there is strong contraction of the urinary bladder, and so the pressure rises so sharply up, and this is what causes urine to be expelled from the urinary bladder during voiding. Let's talk about the micturition reflexes. Now, micturition reflexes are reflex contractions of the filled or filling urinary bladder. They're just reflex contractions. These reflexes are usually initiated by stretch receptors found within the wall of the urinary bladder, as well as within the posterior urethra around the location of the sphincters. So the pressure within the urinary bladder, pressure around the urethra, posterior urethra, is the one that initiates these reflexes. More micturition contractions begin to appear as the bladder fills, which means that if the bladder is empty, then you don't experience those micturition contractions. But as the bladder fills, we have more and more and perhaps stronger and stronger micturition contraction reflexes being experienced. This image shows you such a graph that shows you both the strength as well as the frequency of micturition contractions according to bladder filling. So before that 150, we don't see any single contraction event. We don't see a single micturition contraction. But as we fill towards 200, we can see there are contractions, but again, they're not very strong. Compare that with the contractions that we get when the bladder volume is quite high. The contractions become much more. And this is what causes the discomfort and the strong urge to void. Now, not that contraction will automatically lead to micturition, not quite. You have micturition contractions, but may not lead to voiding. Voiding can only happen at allowed time. So as the bladder fills, if there's a contraction that does not lead to voiding, it will go back. And then another one will come later, then go back. And as the bladder continues to fill, the frequency of the contractions become more, and the strength of the contractions will become more. Now, a complete cycle of a micturition contraction consists of the following. When the bladder contracts, there'll be a rapid increase in the intravesical pressure. So the pressure goes up rapidly, and then there'll be a period of sustained high pressure, a short period of sustained high pressure, then followed by a period of return to the basal tone. So basically, there'll be a contraction that increases the pressure, then sustained a bit, then relax to the basal tone, depending on the volume of urine that is within that urinary bladder at that time. So this usually tends to repeat itself over time as the bladder continues to fill. If a micturition reflex occurs but doesn't succeed to bladder emptying, the reflex becomes inhibited for some minutes or even up to 1 hour before it comes back again. Of course, during that period, the bladder will continue to fill. And when it comes back, it may come back even stronger. So what's the role of the nervous system in micturition? Micturition is a reflex mediated by the autonomic nervous system. Now, the spinal cord is the one that mediates micturition reflex. However, this autonomic reflex can be inhibited and facilitated by some centers within our brain. For example, the cerebral cortex has control over micturition. The cerebral cortex tends to inhibit the micturition reflexes so that they don't happen. You intentionally inhibit them. Remember, these are voluntary mechanisms. The cerebral cortex also helps to contract the external urethral sphincter. So it keeps it at contracted state until when micturition is desired or perhaps appropriate in the social setup that somebody's in. Again, another center that controls micturition is the pons. We have a pontine micturition control center that can either facilitate the process of voiding or can actually inhibit the process of voiding. It can facilitate the micturition reflex or inhibit the micturition reflex, depending on the phase of the urinary bladder, if it is in the storage phase or in the voiding phase. For example, if the pontine center is operating and the bladder is filling, so it is still in the filling phase. If the bladder is in the storage phase, the pontine micturition center inhibits the micturition reflexes. So the reflexes that operate between here are inhibited from the pons. But if it has reached a time that now the bladder needs to empty, the pontine micturition center will then facilitate this particular process of micturition. Now let's look at it this way. Let's say that the bladder has filled now to a point that somebody needs to void. We will have sensations from the urinary bladder wall indicating that the bladder wall is stretched. So we have stretch receptors from the urinary bladder that carry that information to the spinal cord and eventually to the pons. So these impulses carry information to pons regarding how much the urinary bladder is stretched. If it's not adequately stretched, that will be the filling phase. So these things are inhibited. If it is adequately stretched, this will now initiate the voiding phase. So during the voiding phase, this is what happens. The pons, the pontine micturition center is activated by the stretch sensations that come in. The Ponton Micturition Center, once activated, acts on three things. It acts on the sympathetic division of the nervous system to inhibit the sympathetic efferents. If you inhibit the sympathetic efferents, principally the internal urethral sphincter is going to be relaxed. So that will lead to relaxation of the internal urethral sphincter. The second target of the Ponton Micturition Center being activated is the parasympathetic division to the urinary bladder. Now, this one causes the detussor muscle to contract, hence increasing the intravesical pressure. It also helps to open the internal urethral sphincter as well. And so urine can come out easily. The third target of activated Ponton Micturition Center is the somatic efferents to the urinary bladder through the pudendal nerve. So what Ponton Micturition Center does is basically to inhibit the somatic efferents to the external urethral sphincter. And that means that that muscle will therefore also not contract, will relax. Leads to relaxation of the external urethral sphincter. Remember, that one is controlled by skeletal musculature. So that's what happens if the Ponton Micturition Center is activated. If this during the filling phase, which means that the Ponton Micturition Center is not activated, the pons will actually be facilitating storage of urine. It will be inhibiting voiding of urine. And so the reverse mechanisms will apply. We are also aware that we can voluntarily void urine. Voluntary urination is usually initiated by contracting the musculature of the anterior abdominal wall. So you just intentionally contract, especially the muscle anterior abdominal wall, to apply some external pressure on the urinary bladder that will then activate the stretch receptors within the wall of the urinary bladder. However, we know that we are also able to maintain the external urethral sphincter in a contracted state for quite a while in adults. And this usually helps to delay urination until when it is appropriate, until we have the appropriate opportunity for that particular one. So it's a learned ability. We have a learned ability to contract the external urethral sphincter for some time. But remember also there's some things which are associated with its relaxation. There are some conditioned reflexes that can make the external sphincter then feel like relaxing and the bladder contracting, especially when you hear the sound of waters, because your body has already learned that whenever you are voiding urine, there'll be some sound of water. So even if it's not water from your urinary bladder, it's from a tap, can even make you have that sensation of you want to void now and now. They are conditioned reflexes. So this image tries to summarize for us the events that take place in the control of micturition. Let's look at the middle one. Let's assume that the bladder is filling with urine. As it fills, the wall is stretched. So that information is taken by the stretch receptors on the wall of the urinary bladder. The stretch receptors on the wall of the urinary bladder take impulses to the brain. Now, higher centers of the brain, when they receive that, they'll cause or inhibit micturition as appropriate. If it is correct to void, fine, it will allow micturition. If it's not correct to void at that time, it will inhibit the micturition reflexes. The higher centers largely operate by acting on the Ponton centers that control micturition. So we have the storage center as well as the micturition center. if the brain does not want urination to happen, it will act on the ponton storage center. The ponton storage center generally inhibits parasympathetic activity so that there's no contraction of the bladder wall. It also stimulates sympathetic activity so that the bladder sphincter is contracted, urethral sphincter is contracted. It also stimulates the somatic innervation to the external sphincter, so the sphincter remains tight. That is what happens during the storage phase. But if it is during the micturition phase, the voiding phase, the brain can allow that to happen because it will promote, again, these three things. It will act on these three things, or rather, it will act on the parasympathetic division, sympathetic division, as well as the somatic division. Same thing as what the reflexes can also do directly without involving the brain, the higher centers. So if the stretch receptors are activated on the spinal cord, they can actually cause this again to happen. Activate parasympathetic activity so that we have contractions of the detrusor muscle. We have relaxations of the internal urethral sphincter that will lead to micturition. If the stretch receptors are activated, it will lower the sympathetic activity, and so that will be allowed, permitted. Again, if the stretch receptors are activated, it can actually trigger also inhibition of the somatic innervation to the external sphincter, and that will cause the external sphincter also to happen. Remember, this one is voluntary. And so again, micturition happens. Great. So that is urinary bladder and physiology of micturition. We can now finish with the anatomy of the urethra. We'll talk about the male urethra as well as the female urethra. This is how the female urethra looks like in the left image, and this is how the male urethra looks like in the right image. Let's begin by talking about the male urethra. Topographically, the male urethra is long, about 18 to 20 centimeters, and it extends from the bladder neck all the way to its orifice at the tip of the penis. We describe the male urethra to have two segments, the anterior urethra and the posterior urethra, and I'll explain. The posterior urethra has three segments: the preprostatic, which is somewhere there, the prostatic, which is this zone, and the membranous urethra, which is that one. The anterior urethra, on the other hand, has two parts: the bulbar urethra, which is that part, and the penile urethra, which is that segment. So in this image, we see the preprostatic urethra there, prostatic urethra, and membranous urethra. Then we see bulbar urethra there and penile urethra there. The male urethra has both urinary functions as well as reproductive functions, unlike the female urethra that has only urinary functions. So having said that, it means that the male urethra also receives some ducts which carry semen. Semen is deposited into the male urethra. So that's why you see that duct there, ejaculatory duct that opens into the then the anterior urethra. The posterior urethra, as I've already mentioned, has three segments: the preprostatic, prostatic, and membranous segments. The preprostatic urethra is the shortest around that region. It's very short around that region. It's just a transition, by the way, from the bladder neck to the prostate gland. It's a small transition. The prostatic urethra is the region of the male urethra that traverses the prostate gland. So it's located within the substance of the prostate gland. This is the part of the male urethra that is most distensible. So if you are to inject some fluid, this is the part that will balloon out the most. It measures about 3 to 4 centimeters long, but it receives multiple ducts from the prostate glands, as well as 2 ducts, which are called the ejaculatory ducts. So this is the ejaculatory duct. The ejaculatory duct is a duct formed by the union of the vas deferens and the duct of the seminal vesicles. So we have one on the right, one on the left. These are the ejaculatory ducts. They open into the prostatic urethra. The prostate gland itself open via multiple ducts, about 15 to 20 tiny ducts, which open into the prostatic urethra. So this is the prostatic urethra there. This is the membranous urethra. The preprostatic urethra is somewhere in that region. In this image, we see multiple openings of the prostatic ducts into the prostatic urethra. The last one is the membranous urethra. The last segment of the posterior urethra is membranous urethra. This is the part of the male urethra that traverses the pelvic floor. This part of the membranous of the urethra is the one that is surrounded by the external urethral sphincter. So this is the one that is under somatic control, voluntary control. It is the thickest part of the urethra, but also the narrowest part of the male urethra. It is also the shortest if you are to ignore the preprostatic part, and it's a part that is least dilatable. You cannot easily dilate the membranous urethra. So in sagittal section, so this is the prostatic urethra, this is the membranous urethra, and this is the bulbar and penile urethra. Passing through the pelvic floor is the membranous urethra. The anterior urethra, on the other hand, is the region of the male urethra that lies within the corpus spongiosum of the penis and is therefore termed the spongy urethra as well. It measures about 15 centimeters long if the penis is not erect, and consists of the bulbar urethra, this part, and penile urethra, that part. So the bulbar urethra is the part within the bulb of the penis, and the penile urethra is a part within the penis, the shaft of the penis. The bulbar urethra is the widest part of the male urethra, actually, without any intervention that caused it to distend. So it's the widest part of the male urethra. It is found within the bulb of the penis at the perineum. It receives openings of the corpus glands. So the bulbourethral glands of corpus empty into the bulbar urethra. The penile urethra, on the other hand, is found at the shaft of the penis, which is still within the corpus spongiosum. Towards its opening, towards its termination within the glands, the penile urethra is slightly dilated in a region we call the navicular fossa, just before it opens. So this one is the penile urethra. Just before it opens within the glans penis, there's that dilatation which we call the navicular fossa. Then eventually the urethral meatus at the tip of the glans penis. The penile urethra, or rather the spongy urethra, receives openings for numerous mucus urethral glands. There are a lot of mucus urethral glands, which we call the glands of Lita, that are located around the urethra. So they open into the penile urethra or into the anterior urethra. Look at this. This is the histology slide of corpus spongiosum. So this is the urethra. These are the paraurethral glands, also called the glands of Leydig, which empty into the anterior urethra. Okay, that is male urethra. Now let's talk about the female urethra. Topographically, the female urethra is embedded within the anterior wall of the vagina. So if this is the urinary bladder, this is the female urethra, this is the vagina. So it's embedded within the anterior wall of the vagina. It measures about 4 centimeters long and 6 millimeters wide. So it's like wider than the male urethra, but shorter than the male urethra. This is it in profile as a female urethra from the urinary bladder all the way to its external orifice. As we can see, the female urethra crosses the pelvic floor and ends into the vestibule of the vulva. So if this is the vulva, the vestibule is there. The female urethra empties into the vestibule, usually at around 12 o'clock position of the vestibule. That's where we have opening of the female urethra. There's some small mucous urethral glands that open into the urethra as well. Tiny of them, many of them, as we can see in that particular image. So there are several mucous glands that empty into the urethra as well in female, just like how it happens in males. The paraurethral glands of skin also empty here, just close to the opening of the urethra. The duct open on the lateral margin of the external urethral orifice. We call them the paraurethral glands of skin, or the lesser vestibular glands of skin. Great, let's finish with some differences between the male and the female urethra. We can start with the length. Definitely the male is longer than the female urethra. We can also talk about the diameter. The male urethra is narrower than the male urethra. We can talk about the orientation. The female urethra is relatively straight. The male urethra is angulated. Now you might be tempted to say, if the penis is erect, then male urethra will be straight, but that's still not true. Remember that two angulations. The angulation at the membranous urethra is constant, whether the penis is erect or not. The only angulation that changes is the angulation between the vulva and the penile urethra. That's the one that changes. If the penis is erect, then that angulation ceases to exist. The penis becomes straight. But otherwise, the penis is still angulated at the membranous urethra. The male urethra is still angulated at the membranous urethra, while the female urethra is relatively straight. In terms of site of opening, the male urethra opens externally at the tip of the glans penis. The opening of the female urethra is internal. You may have to peep in the vestibule for you to see that. In terms of function, the male urethra has both urinary as well as reproductive functions, the part of that's followed by semen as well. It's part of the male genital duct system, while in female urethra, it is only for urinary functions. Great, so those are the differences between male and the female urethra, and that summarizes that lecture on the structural organization of urinary passageways, as well as the physiology of micturition. The last part of the lecture series on the urinary system will be on development and congenital malformations of the urinary system. Thank you very much. We'll stop there for now.